And we're now going to move to one of the pieces of the quadruple aim we talked about, and that's our care providers themselves. And we have with us Dr. Steve Houghland. He's the Chief Medical Officer for the Kentucky Primary Care Association. He's a primary care physician himself, has done many years of clinical care, but also served in many leadership positions. So we're very happy to have Steve with us today to share the provider perspective.
Thanks, John. Good morning, everyone. Glad to be here. Many years, yeah, it feels even more sometimes. I will say that I'm leaving you a little slide poor, so I apologize. But I think starting off, just want to give you, for those that aren't familiar with the Kentucky Primary Care Association, just a high-level view of what we do and represent. So the association has a clinically integrated network that represents over 90 tax ID numbers in Kentucky. 24 FQHCs. We hold value-based agreements with multiple payers in multiple lines of business, so Medicare, Medicaid, as well as commercial and marketplace. In those agreements, there's over 500,000 Kentuckians that are attributed to these providers. And annually, we see over 1 million unique patients. So about a quarter of the population of Kentucky is, a quarter to a fifth are seen in our network every year. Next slide. So jump in. A lot of the information has already been shared with my colleagues, and it's been really, really insightful. And I don't have a lot to add that is unique, but maybe a little different perspective. Yeah, so providers, I think the reality is that depending on where they are in the world and their development, they may utilize this type of information in very different ways. And so, for example, a hospital system will utilize it in one way, whereas a independent network will use it in a slightly different way. And then individual providers, you may not have the capacity to access it at all. But I think, well, we all need to be thoughtful about how information is informing policy. We are in a position where you only know what you know, and you get very limited perspectives at times. This type of information for a network like ours will be really insightful as we look at pursuing new opportunities. I mentioned that we have multiple value-based agreements. Making a decision of where we want to work with payers to develop another one, whenever you're only seeing the information that you have at hand, it's difficult to decide, is it a good business decision to make efforts to grow? And also to just refine your own processes internally. When you look at where most of healthcare delivery occurs, it's not at the primary care provider's office. And the cost certainly isn't primarily at the primary care provider. It ranges from 5 to 10, 11% of the healthcare expenditures are limited to primary care services. So obviously the vast majority are at pharmacy, outpatient services that are hospital-based or in acute hospitalizations. And so only seeing the small window that you have, it makes it very difficult to refine your processes to identify what is the most cost-effective course of action. Jenny had mentioned that price has been increasing at a pace more than utilization. Whenever we're looking at those macro numbers, the trends are helpful, but when you dig down deeper, is it increasing at a disproportionate rate because the site of service is what has been actually growing in utilization? And it's not lower cost, high quality outpatient services, but ER utilization or hospitalizations have been increasing. And so that's where information like this that you don't necessarily have as a provider can help you determine what are the best next steps, and how do you develop different programs like transition programs, for example, or make different types of investments. The ability to compare to local benchmarks is something that we generally do not have today. Within our network, we can compare the performance within a practice or across different groups within the network, but we can't really compare us to others in the community very easily. Helping determine what is the most cost-effective care, and I think that's what I refer to in consumer navigation here, is helping them navigate the system to provide to receive services that are more cost-effective and higher value. A value in healthcare really is a relationship between cost and quality over time, and it's not always looking at what is the immediate unit cost that is being experienced, but what is the experience over time. And seeing only your own performance and not having good feedback loops from the hospital systems, et cetera, does limit your ability to help people navigate the healthcare system more effectively. So it was mentioned consumer shopping. I think it's also helping the providers define what is the most cost-effective sources of services within their own communities to make those referrals. Assessing utilization and performance. That's extremely important. It's becoming more and more important as providers are being asked to take on more risk within the healthcare system. And it's really difficult for them to be able to do that. This type of data will help inform them on what are good decisions to make and when should they take on different types of risk, and how they help develop delivery models to deliver the highest value for their communities. I mentioned that about half of our members that are seen are in value-based contracts. And as we shift more and more out into the risk space, that downside risk will be moved, is being looked to be pushed to providers. It's a very challenging place to be whenever you don't understand where most of the cost is occurring, and that is outside of their four walls. And so additional information will be extremely helpful for that. And then we have the Health Information Exchange is really helpful in providing information to us. It does not really hit on cost, and it is currently limited. It's primarily kind of informed by hospital care and groups that are attached to hospitals, but the rest of the system, the healthcare system in Kentucky, isn't contributing a huge amount of information to the HIE. And so additional data sets that are more universal will be really helpful. And it becomes a point of comparison for our EHRs and administrative systems to as a check and balance to validate what we're seeing and to provide additional information. At the end of the day, I think the utilization will depend somewhat on what is included in the APCD and how it is determined to be accessed. There is a wealth of information that exists in the world today, but it's been mentioned before, it's not the most easily accessed. And a single source of information, and if you will, a source of truth, will help with the development of new delivery models. And to be completely honest, providers are being challenged to start thinking a lot more the way other risk-bearing entities are, whether that's the employers or it is the health plans. And so having more information to be able to accept the risk and develop new systems, and if you will, creates a new business and a new ability to be entrepreneurial, is something that 10 years ago really wasn't thought that much about, and certainly not 20 years ago, but that is going to be a lot more of the future. And you see more and more healthcare providers bringing in a lot of the same skill sets that has existed in the insurance space for quite some time with actuaries and decision support. And data really is the foundation for the analysis to decide where do we strike out and develop new models that will help Kentuckians. And so I will pause here and please ask questions in the chat, and I think we'll have time to address later in the presentation.